Hello, my name is Dr. Jamey Lister. I'm an assistant professor at Rutgers University School of Social Work, and my co-author on this paper is Dr. Jamey Lister. She's a clinical psychologist at Rutgers University Behavioral Healthcare. Both of us are in New Jersey in the United States. My expertise is in rural health and health disparities and the treatment of opioid use disorder, and I'm also someone who was raised in a rural community. Holly's expertise is in health systems and improving access to care in those systems. So what sparked our interest in this paper was we noticed that changes were occurring to treatment protocols at opioid treatment programs during the COVID-19 pandemic. And we thought that presented an opportunity to reconsider how some of those adaptations might be maintained long-term as a means of improving access to care for rural communities in the U.S. This was important. As an example, fewer than 5% of opioid treatment programs in the United States are in rural areas. We also want to focus on the role of methadone in the rural U.S. to give rural communities a choice in the type of treatment they receive, since most initiatives and research so far have focused on other medications like buprenorphine and naltrexone. So we came up with 3 recommendations to expand access to care for rural residents in the U.S. long-term. First was to maintain the more flexible methadone dispensing and take-home models used during the COVID-19 pandemic. For example, allowing other folks to pick up medications for the patient and longer take-home doses. Second, we also recommended maintaining telehealth services not only through greater reimbursement, but enabling telehealth for patients that don't have video-enabled devices or smartphones. In addition, we recommend that the use of barcoded oral swabs be used as a means of drug testing as opposed to requiring patients to travel in to do urine drug screens. When we look at some of these COVID-19 adaptations, we also wanted to look at other countries and what they were doing for their methadone treatment prior to the pandemic. So we looked at the United Kingdom, Canada, and Australia, and we really focused on the model used in Scotland as a comparator. So with that in mind, we were recommending that after patients from rural areas go through induction and are stabilized on methadone, that thereafter their care be transitioned to other providers that are not necessarily at the opioid treatment programs, but could be in primary care, and that they're allowed to pick up their medications from primary care or community pharmacies, as well as have longer take-home doses. So how do we get there? I think the biggest thing that's needed are health policymakers at the federal and state level to lay out initiatives that allow rural patients to have exemptions to standard regulations or treatment protocols that help address their treatment barriers. In addition, more research is needed to know how rural stakeholders view methadone treatment, both patients or consumers as well as providers. And last, we really hope in conclusion that opioid treatment programs, treatment regulatory authorities, and health policymakers consider these recommendations as a means of improving access to methadone for rural communities in the United States. Thanks.